Okay, so myeloid disorders. Myeloid disorders, this will include everything relatively that originated from the myeloid stem cells. Now, when we talk about myeloid diseases, usually, as I mentioned before, we meaning that non-lymphoid cells or cell line is affected. This is going to affect the erythroid or the granulocytes, monocytes, and thrombocytes lineage. And this is how we do have, for example, in a case of acute myeloid leukemia, because these are the subpopulation of the acute myeloid leukemia. Sometimes, however, we say that what is non-lymphoid or non-erythroid. You can find this one. For example, in the myeloid and erythroid ratio in the bone marrow when we are going to discuss the chronic myeloid leukemia. However, you have to be very careful about it because when you talk about, for example, multiple myeloma is not a myeloid malignancy. This is only expressing the origin of the diseases because in Greek the myelon is meaning the bone marrow. So anything what is a myeloid that affecting mostly in our case the myeloid. Now when we talking about the myeloid disorders, we can separate into two different parts. One that is we call is a non-malignant diseases and other is a malignant diseases. Let's see the non-malignant first. The non-malignants that can be manifested as a granulocytosis or leukemoid reaction, we will talk about later, or we do have granulocytopenia, decreased number of the granuloid cell line, or agranulocytosis when we have no granulocytes at all. And we can have a problem with the function of the granulocytes, and these are non-malignant disorders. The malignant one, if you want to see the special distribution and classification of these diseases, I put here a link that you can click on it and you will see that today's how the WHO classified. Now, malignant diseases involving the acute myeloid leukemias or the myeloproliferative neoplasm and myelodysplastic syndrome. Now, if you look at, for example, the peripheral smear, these cells that you can see on the picture that can be found in a normal, healthy individual peripheral smear, such as, for example, we do see here the leukocytes, we do see here a monocytes, we do see a neutrophil segmented one or a neutrophil band or eosinophil segment and a basophil one. Of course, the most common one is the neutrophil, and after eosinophil and very few is a basophil. There is a common say that is saying that monkey doesn't eat bananas or something like that, that is showing that which is the most common one and which is the less common cell type. Neutrophilia. Let's start when we do have an increased number of the neutrophil granulocytes. We call it neutrophilia when the granulocytes count is over 7.5 giga per liter. Usually we meaning the absolute values, not the relative values, not the percentage, because you can measure the granulocytes count directly. Now, what can be the pathogenesis or what could be the pathogenesis of the neutrophilias? Now, this kind of neutrophil scale can be originated from the bone marrow directly, or it can come from the marginal pool that is located in close to the vessel wall. And another possibility, if this pool cannot marginate to the vessels. So this all case can increase the neutrophil count. For example, When you eat, usually after eating, you do have a granulocytosis neutrophilia because, or any kind of sympathetic stimulation that will increase the release from the marginal fluid or release from the bone marrow, so the patient will have a neutrophilia without having any kind of infection. However, some other case when we do have a bacterial infection, we do have neutrophilia, except in typhoid fever or brucellosis, because in this case we do have usually neutropenia, so the decrease of the granulocytes count. But any other inflammation such as a pancreatitis or any kind of abscesses or hematological malignancies can be manifested as a neutrophilia, or tissue necrosis, such as, for example, myocardial MI or pulmonary infarction, or other metabolic disorders that will cause some inflammatory reactions, such as a gut or diabetic ketoacidotic coma as well. Or drug, as I mentioned before, epinephrine when we do have a sympathetic stimulation, or corticosteroids, or if somebody got, for example, a granulocrystalline stimulating factor injection, this will increase the number of the neutrophil cells. Now, this is how the neutrophilia looks like. When you look at a view, usually one view means that we are using a 400 times magnification, and how many nucleated cells you do see per view. Usually only one or maximum of two you can see, and here you do see that mostly the maturated cells can be seen. Very few band cells you do see here. Mostly they are segmented granulocytes. Now, eosinophilia, another very common situation, when we do have an increased eosinophil count when the absolute value is over 0.5 giga per liter. Now, as you see here in the periphery, we do see usually you do see this binucleated cells, and inside we do see this reddish, little bit gross granulation inside. The etiology mostly is due to the parasites infection or allergic infection, neoplastic diseases, or immunological diseases such as the hyperimmunoglobulin syndrome and acute skin diseases, dermatitis herpetiformis, that can cause eosinophilia. This is why it's a mnemonic. If you read through, that's a panic. This is a panic that can cause eosinophilia. But mostly the first thing that you have to think about parasites infection or allergic diseases. These are the two, is a very common one. Leukemoid reaction, now this is a little bit more than a granulocytosis. If we do have any inflammatory reaction, what will happen? The bone marrow is stimulated due to the inflammatory leukocyte or cytokines and general systemic reaction, and not only the number of these white blood cells will increase, but we do have a left shift. What this left shift means? Usually in the periphery, as I showed before, we do see mostly the segmented one, and we do see very few band and maybe a few metamyelocytes, but we do not see any myelocytes or promyelocytes and no myeloblast at all. Now, when we do have an infection, what will happen? An early stage can occur in the periphery, such as we do have still segmented neutrophils, but more band or more metamyelocytes can be seen compared to the control. And if you draw this distribution curve, you will see that this curve is left shifted toward the less maturated positions. Now, when we do have a leukemoid reaction, leukemoid means looks like leukemia, but is not leukemia, but this left shift is so severe one that the peripheral picture could show a picture of mostly the chronic myeloid leukemias. Now, And especially in these two cases, in leukemias and in leukemoid reaction, the similar symptoms can develop, but from different reasons. Let's see what, as I already said, the leukemoid reaction. When we do have an agent that causes infection, that infection as a systemic reaction will cause fever and increase white blood cell count. So this is the scheme because the body wants to be protected. However, when we do have a leukemia, and due to the immunodeficiency or due to, let's see, the proliferation of the white blood cells, and we still have an increased white blood cell count, and we do see fever and infection, but not because the infection induces, let's see, the increased number of the white blood cell, but because these white blood cells autonomically can proliferate and they are not fully developed, so they are unable to protect the body against the invader, we do have again fever and infection. So this is the same symptoms, but the cause is completely different. Now, granulocytopenia or neutropenia, when we do have a decreased number of the neutrophils in the periphery. Usually we call it when the number of the granulocytes is less than 0.5 giga per liter. Now, what could be the clinical symptoms? Mostly the clinical symptoms correlate with the decrease of the cell count. If we do have more than 1 giga per liter, relatively there is no symptoms of maybe very mild infection diseases, repeated infection can occur. If we do have between 0.5 or 1 giga per liter, now this patient has a higher risk for infection and very easily can be infected or can develop fever or generalized infection. If we do have less than 0.5 giga per liter, yes, very severe bacterial and fungal infection and further sepsis can develop in this situation. Now, diagnosis. How we are going to diagnose granulocytopenia? First of all, and we have to figure out what was the problem with that. The peripheral blood smear and white blood cell differentiation, the absolute cell count, it will help us for sure. Another thing, the clinical data or the anamnestic symptoms again can help us that the patient could have a decrease, for example, granulocyte count. If somebody, for example, had a cytotoxic therapy or chemotherapy or radiation, they could have a granulocytopenia. Now, serological studies that if we do have some autoantibodies that can directed against the white blood cell count. That's, for example, in systemic lupus erythematosus, we can have less granulocyte count in the periphery, but more red blood cells and platelet count decreases as well. And for sure, a bone marrow biopsy can be used to evaluate how the bone marrow structure looks like. Now, therapy is depending on the cause of the granulocytopenia. First of all, we have to stop the cause of this decrease of the granulocytopenia, remove the possible pathogenic factors such as a drug, for example, or if we could, we should alter the underlying therapy as well. Or we should give granulomonocytes clonal stimulating factor or granulocytes clonal stimulating factor, and the patient should be protected against the infectious agents, so antibiotic treatment should be applied in this patient. And in a case of problem in antibody-mediated diseases, plasmapheresis, for example, or steroid, or intravenous immunoglobulin, for example, could be applied, or immunosuppression could be applied. And further, the stem cell transplantation can be used to normalize the granulocytopenia. Now, what could be the cause of the granulocytopenia? Already mentioned some. Basically, we can have a problem when we do have a decreased production in the bone marrow. Now, this decreased production can be, for example, aplasia. If we do have a bone marrow injury that could be caused by for example, radiation or chemical, benzol or chloramphenicol, an antibiotic can cause it, or anti-stem cell antibodies, or tumor growth in the bone marrow and as a space occupying feature that can cause a decrease of the certain normal clone in the bone marrow that's happening in leukemia, lymphoma, or primary bone tumor or metastasis. Or if we do have a problem with the surrounding, the extracellular spaces, for example, that happening in osteomyelosclerosis, that's a fibrotic condition that alters the bone marrow and the cells cannot adhere to the extracellular matrix, so they do have a developmental and proliferation problem. And we can have a problem with the maturation, for example, a genetic problem, the defect of elastase 2 or Kostman syndrome, or cyclic neutropenia, folate deficiency we mentioned in anemias, for example, or myelodysplastic syndrome. This is what we are going to discuss later on. And we can have an increased loss of the granulocytes. Immune-mediated one, I already mentioned that systemic lupus erythematodes, rheumatoid fever, for example, or alloantibodies, for example, after usually develops a stem cells transplantation. And this, for example, can be caused. Or non-immune-mediated neutropenias, usually when we do have a bacterial fungal infection and the consumption is increasing, or abnormal distribution if somebody has, for example, hypersplenia, that can happen in cirrhosis in the patient. And the combined problem, usually what I listed for in this previously, these are the combination can happen and the cell turnover can be altered as well. Now, what is the agranulocytosis? Agranulocytosis usually when we do have less than 0.5 gram per liter granulocytes count in the periphery. And this usually develops as suddenly. And what will happen? The cause of it can be idiopathic one. We have no idea why it is different. Usually this is a stem cell defect or some kind of immune-mediated processes, or iatrogenically when somebody has some irradiation or drug, and that decreases the granulocyte count to the almost to the none. Pathogenesis, as I mentioned, that is immune-mediated when we have a drug, and that's a hapten, and that can form as an antigen and induces antibody production, and the immune complex usually causes the lysis of these cells. What will be the symptoms when we do have agranulocytosis? Usually fever, sore throat, angina tonsillaris, and stomatitis aftosa, as I'm showing here. That could be a repeated one, so usually the patient is suffering of this condition. The therapy, if we know what drug could cause this one, for example, chloramphenicol was used, you can stop it, or if the patient has some kind of infection, you have to use antibiotic treatment, and later on, if it's not coming back, you can use some stimulator of the granulocyte proliferation as a granulocyte clone stimulating factor. Now, the impaired function of the granulocytes. There are several functions of the granulocytes we do have. Let's start. Basically, generally inhibiting the granulocytes function, such as, for example, the steroids or uremic toxins. If somebody is suffering, for example, kidney diseases, that can alter the granulocytes function as well. Or if you do have uremia. Another problem, for example, can be if you do have some enzyme defects. For example, the NADPH oxidase or myeloproliferative deficiency, again, the function of the granulocytes be affected. And mostly this patient who's suffering, that will develop some granulomatosis diseases, because any kind of acute inflammatory reaction, that's be chronic one because it cannot be consolidated. Or another one, we can have a problem with the adhesion or a chemotaxis of the leukocytes as well. That's another problem. Or we do have a combined defect. That's a very famous one. The Chediak-Higashi syndrome is not so common one. We do have a problem with the phagolysosome development, so the lysosomes and the phagosomes cannot be fused. Some kind of hereditary problem can develop. So this all will affecting the granulocytes function. Now let's talk about the malignant diseases of the myeloid system. Now this is what we will have in the periphery, especially here when we do have the chronic myeloid leukemia peripheral smear. It almost looks like as a bone marrow, except we don't see any kind of erythroid cells, erythroid precursors, or megakaryote precursors. But as you do see here, it looks like we do see some early precursors of the myeloid, such as, for example, the promyelocytes, or maybe the myeloblast, but mostly the myelocytes and the metamyelocytes. These are the 2 or 3 cell type that is very frequently elevated in the peripheral picture, peripheral smear. Now, leukemias. When we're talking about leukemias, it's meaning that the blood is whitish, so this white bloodedness. It's a systemic and diffuse autonomous proliferation of the myeloid or the lymphoid cells, and mostly involves in the periphery, in the blood stream. This is why it's called the leukemias. And it originates usually as a monoclonal disease, so it's originated from the malignant clone that starts to proliferate and invading into the peripheral blood. Now, not only the proliferating capability increases, but the apoptotic, or let's say the contact inhibition, is altered in these cells, so they won't feel that they're so crowded. And what will happen in the bone marrow when we do have this kind of clone that starts to proliferate and not sensing the contact of the other cells, they will divide and occupying the spaces. And what will do the normal healthy cells that they do have a normal contact inhibition? They will stop dividing. This is why in the periphery, first you can have less for example, white blood cells, because they are not going, the clone not going to alter the peripheral bloodstream, but only stays in the bone marrow. But the healthy cells, they be less, and this way less cells gets to the periphery. So at the beginning, especially, we could have less white blood cells in the periphery. Now, what will be the characteristic features of the leukemias? As I mentioned, the malignant clone has proliferative advantage and over the normal cells, and the normal cell growth is inhibited. And the clinical consequence, the hematopoiesis of affected cell line becomes colonial one, and the normal cells will decrease in the periphery. This is what I mentioned before. And the malignant cells may infiltrate the extramedullary tissue as well. So not only in the bloodstream, but they can infiltrate, for example, organs, such as, for example, lymphatic nodes, such as testis, for example, or they can infiltrate the spleen or liver or the skin, for example. And that will cause organ damage and impaired function of the damage. Or another thing, the white blood cell count may be significantly increased, and when it's significantly increased, we can have a circulatory problem such as the hyperviscosity, or leukostasis can develop when they are plugging the white blood cells, plugging the vasculature, and we don't have a normal circulation, and we can have perfusion abnormalities in the periphery. Now, how do we classify the leukemias? The leukemias can be classified based on the onset, whether the onset is acute, and usually the propagation of the disease is very acute and very rapid one. That's an acute. And the chronic one slowly and take decades to develop, for example, these diseases. So the patient survives years without having any kind of treatment. However, who's suffering in an acute leukemia, without treatment, they won't live more than a few months. And other possibilities how we can distinguish between the cells, what kind of cells is going to proliferate, such as the myeloid origin diseases or lymphoid origin diseases. Now, based on these four classifications, we can have acute myeloid, acute leukemia, acute lymphoid leukemia, chronic myeloid leukemia, and chronic lymphoid leukemia. So far, we are going to mention only the myeloid one. Now, what will happen? Usually the leukemia needs a multiple transformation, multiple genetic changes, mutations. We do have a normal hematopoiesis, for example, and any kind of changes, genetic changes occur. Usually at the beginning we do have a proliferative advantage genetic changes, and now we do have a clonal hematopoiesis and differentiated, so we do have more progression, more proliferation, and if we stay here we do have, it's called a chronic leukemia, or remain maybe unnoticed that because it stays inside the bone marrow. Usually this kind of clone cells is persist in our body for decades before they start to proliferate so rapidly, as they're occupying the bone marrow or in a bloodstream, and they won't be recognized at all. However, when another mutation happening, for example, they do have a maturation inhibition, that the cells won't be matured completely, or they do have an altered, for example, contact inhibition problem. Now that cells as a hematopoiesis be undifferentiated, and now is turning to the acute leukemia. Usually a chronic clonal hematological condition very frequently turned into acute leukemia. That's a very important one. Now let's talk about first the acute myeloid leukemia. Now, what we call as a acute leukemia, usually when we do have more than 20% of blast cells in the bone marrow or in the peripheral blood. Normally in the periphery there is no blast cells at all. However, in the bone marrow we do have blast cells, but that's a least number of the cells what we do see the early one, because they are going to proliferate. So normally in the bone marrow you do see less than 5% blast cells. If you do see more than 20%, that's acute leukemia. In chronic situation, yes, you can have more than 5%, usually between 5 and 20%. This is the range when we do talk about the chronic leukemias. In the next, I'm mentioning something about the epidemiology, etiology, classification. That's important thing, especially in acute leukemia. Hematological smears, how it looks like, clinical causes, symptoms and complications, and diagnostic methods, and differential diagnostic problems, and therapeutic approach as well. Especially for the final one, you don't need to too much about the theoretical approaches, except in some cases that is so the pathogenesis or the cellular effect is so known that you can mention this kind of treatment. Now let's see the epidemiology of the acute myeloid leukemia. The incidence relatively is not too much, about 2.5 per 100,000 cases per year in the average population. But if you count, let's see, the elderly one, for example, over 65, it's about 4 times higher, about 10 in 100,000 cases per year in over 60 years. It can occur any ages. So it's not only the elderly, it has a little increase over by age. It's most common in men. Usually the all hematological diseases is more common one in men. About 80% of the acute leukemias in adults is acute myeloid leukemia. In contrast with the children, because children, the most common type of leukemia is acute lymphoid leukemia. Another problem, it's problem for an adult one, that in adulthood, the acute myeloid leukemia the treatment is not as good as, for example, the treatment for an acute lymphoid leukemia in children, because about more than 90% of the acute lymphoid leukemia can be treated in children, while in acute myeloid one is not as high. But it increases when we do have a more advanced technique. Now, etiology. It can be, basically, we don't know exactly what the etiological process of the acute myeloid leukemia. The most common one is for idiopathic one, so we don't know what the cause is. But it, for example, genetic factors. If somebody is suffering from Down syndrome or Klinefelter syndrome, they have a higher tendency to develop acute leukemias. Ionizing radiation can increase this, or chemicals or drugs, as I mentioned before, can induce the changes of the stem cells. Or if somebody suffers, for example, the chronic clonal hematological diseases, such as the chronic myeloid leukemia or myelodysplastic syndrome, and basically what I mentioned, the majority, it doesn't have any kind of correlation. And heredity could be some kind of familial predisposition, because in those family they suffer the acute leukemia, the member of the family has a higher risk to develop acute leukemias, any kind of hematological diseases. Now the classification. There are two types of classification we do have. One is a older one, the ancient one, and usually this is outdated by today, but you still have to know it, because first of all, the clinician usually is talking about this kind of distribution of the acute leukemia. And another thing, before you can do the genetic evaluation of the cell type, you have to start treating the patient. And this FAB classification, or let's call the French, American, British classification, this is based on the morphological changes of the cells plus the type of the cells what we have. So this is can be, for example, evaluated by the light microscope, and we can guess very closely what the problem with this patient. As you see here, this FAB classification is ranging from M0 to M7, so these 8 groups we have. At the beginning from M0 to M3, usually this classification is according to the differentiation of the leukemic cells, such as an undifferentiated one, or myeloblastic one, or myeloblastic with maturation, or promyelocytic one. Later on, from M4 to M7, the type of which line is affected by the leukemia, this is how it's classified. This classification is based mostly on the cytochemical reaction. So what kind of chemical substance or enzyme can be detected by special staining method in the leukemic cells? Today they are not using as much, or in some lab, for example, they don't have any possibilities to use this kind of method. The next one, the WHO classification, is more advanced, and usually they will consider not only the morphological features, but the genetic alteration as well. Now, in this case, we do have 4 subtypes, such as the first one, it's a best, for example, to have it. That's an acute myeloid leukemia with recurrent genetic defects. There are some very special ones. For example, here, the promyelocytic acute leukemia, when we do have a chromosome 15 to 17 translocation and the retinoic acid receptor problem. This is, for example, is belonging to here. But there are much more, almost 40 subgroup that we have here, but you don't need to know this subgroup. But it's very good, because when you treat the patient, you can have a good idea how these different, very specific group responding to the very certain therapies or the transplantation, for example. Another group is not so good because usually this is some kind of acute myeloid leukemia when the patient first of all had some myelodysplastic syndrome or myeloproliferative neoplasia. The survival is less comparing to the first group. The third one is a secondary, or we could say that the therapy-induced acute myeloid leukemia. Usually this kind of acute leukemia develops in those patients who receiving some kind of irradiation or chemotherapy for some other malignant reason, for example, testicular tumor or lung tumor or prostatic cancer or any other or breast cancer, and this kind of chemotherapeutic agent or radiation lead to the development of acute myeloid leukemia. The fourth group usually is going to have this not otherwise specified, or we don't know yet what kind of problem, what kind of genetic alteration can be in this group, and this group is classified based on the French, American, British. Now it's a good news that M3, that's as I mentioned, the promyelocytic leukemia, is out of this group, so the Fab now has only 7, not 8, and this M3 that I mentioned, that's a very stable genetic alteration, the chromosomes 15 to 17 translocation, got back into the first group that we have here. Now, let's see the clinical course and complication of acute myeloid leukemia. Usually, the symptoms is going to develop suddenly. Patient will complain some general signs such as weakness, tiredness. A lot of people suffer of night sweats or fever or weight loss. Splenomegaly, hepatomegaly, lymphadenopathy can be seen, or easy bacterial fungal infection, repeated infection that's usually altered granulocyte count or decreased granulocyte count, or bleeding tendency. This is due to the thrombocytopenia when the mass effect in the bone marrow that's suppressing the granulocyte development or the megakaryocyte development. Anemia is another common one, very similarly what thrombocytopenia develops. Tumor cell may infiltrate some extramedullary tissue, gingiva, for example, skin, central nervous system, and can be the sign, for example, some neurological symptoms, testis, bone, lung. DIC, disseminated intravascular coagulation, may develop, especially in promyelocytic acute leukemia, very frequently. The large number of leukocytes can cause leukemic thrombi. That is not a platelet, that's a leukostasis, as I mentioned, when the white blood cells, when it's over, for example, 50 giga per liter, that can plug the small vessels. Hyperviscosity that may cause microcircular problem, and that can alter the heart function as well. In very rare condition, but osteomyelofibrosis can develop in this patient. Or the increased cell turnover can lead to the development of gut, for example. Hyperuricemia can develop. And a lot of cases, this can develop due to the chemotherapy. This is why they are giving allopurinol to inhibit the metabolism of the uric acid. Chemotherapy may cause tumor lysis syndrome, as we discussed in the kidney, in hyperkalemia or hyperphosphatemia can develop in this patient. But in a lot of cases that's a fatal, and we cannot cure the patient. And because this condition is very dangerous and very fast fulminant development can be expected, the patient needs urgently seen by hematologist. This is why it's very important one. If you are a dermatologist, if you are, for example, a dentist, you should know the sign of these acute leukemias. For example, myeloid sarcoma can be manifested under the skin, for example, or gingival hypertrophy can occur. So these kind of very important syndromes can be seen, and you have to immediately send the patient to the hematologist. Now let's see the diagnostic method. First of all, we can look at the clinical symptoms, how fast it's developed, what kind of symptoms are mentioned before, the fever, night sweat, etc., etc. Another thing, the peripheral blood. This is the first one they are taking, and if we do see a blast in the periphery, but white blood cell is not elevated, it can happen, but blast never can occur in the periphery. Another important one in acute leukemia is called the hiatus leukemicus. Now, what does a hiatus leukemicus mean? Hiatus leukemicus means that we do have an unmaturated cell clone in the periphery that's coming from the altered clone, so the blast cells, and we do have the fully maturated cells that is coming out from the normal cells from the bone marrow. But we don't see anything between these two, so that because only the normally maturating cells can reach the periphery, and only the blast cells can reach the periphery. That is a normal one, that are not going to attach the extracellular matrix, while the normal one is attaching to extracellular matrix. So the blast to the normal blast stays inside the bone marrow. However, the abnormal one gets to the periphery, and this is what is called hiatus leukemicus. And a lot of cases, the patient could have anemia or thrombocytopenia or granulocytopenia, usually at the beginning. If we take a bone marrow aspiration, the blast ratio is over 20%. This is, as mentioned, that's a diagnosis for acute leukemia. And the laboratory test, for example, showing that uric acid level is higher one, or LDH level is higher one due to the increased cell turnover. Cytogenetics, for example, or cytochemical reaction, they are not using, but now the cytogenetic test is used, or immunophenotyping. That's a CD markers. This is what you have to know, some CD markers, such as for example, in myeloid one, a CD34, that's a general marker, or CD117, or CD33, 13, or CD15. So you have to mention some markers for the myeloid one. And especially we have to test for the current genetic abnormalities, what chromosome and what translocation occurs in the patient. Now, Auer wrote, this is one feature that can be used to diagnose immediately an acute myeloid leukemia. This Auer wrote is a cytosolic inclusion, and especially it could occur in promyelocytic leukemia, but not all of them. But if you do see, it's a very good clue to know that that's a myeloid leukemia, and you can say that's possible that's a promyelocytic leukemia. Now, this kind of road that can have some thromboplastic activity, so they can induce the coagulation cascade and can induce disseminated intravascular coagulation. Now let's compare the acute myeloid versus acute lymphoid leukemia in the differential diagnosis, for example. The prognosis of the childhood acute lymphoid leukemia is very excellent one, in a case, especially if it gets proper treatment on time. The prognosis is much less favorable for acute lymphoid leukemia in adulthood and for acute myeloid as well. Now here you can see the incidence and the age correlation with the age as well. As you see here, the acute lymphoid leukemia usually has two peaks in childhood. Usually one occurs around age of 4 or so, and they do have another one maybe age of 7, but is less common one after that. And as you see here, in males especially, it increases over age of 80 or so in acute lymphoid one, and that's a very bad characteristic feature if somebody develops in the elderly in acute lymphoid leukemia. In acute myeloid one, as you do see that this is increases over 50 or over 60, and they do have a linear correlation, and male, if you count, is about 2 or 3 times much higher the incidence than in females. If you do see, for example, the smear or the picture, as you see, they different a little bit. Lymphoblasts usually they don't have a bigger cytoplasm. They do have lighter nucleated cells, as you do see here, but not as much as in the myeloid one. Another thing, if you do see light nucleoli, that's mostly myeloblast. If you do see granulation, that's mostly myeloid cells. So there are some characteristic feature that the hematologist can use to differentiate between the myeloid and lymphoid diseases. And if you be a hematologist, that can be used immediately to characterize or make a pre-diagnosis before you do have the genetic and CD marker evaluation. Now, how can we use the peripheral to diagnose this acute myeloid leukemia? As I mentioned, that's a hiatus leukemicus. What is hiatus leukemicus? I already explained you, but normally what we do see in the periphery, only we do see the maturated cells such as a segmented, band, and juvenile cell or metamyelocytes, and nothing before this stage. In acute one, we do see the myeloblast, the blast, that the clone, the abnormal clone, and we do see the maturated, but nothing between these two. In chronic situation, we do see all of that. Mostly we do see the promyelocytes, myelocytes, and metamyelocyte stages in the periphery. So these can be used to differentiate the acute myeloid or acute or chronic myeloid leukemias easily. Now, therapy. What kind of therapy can be used? There are, for example, some drug therapy, some classical chemotherapy to kill the tumor cells. This is usually case has an induction and consolidation and maintenance therapy. What they're using different cytotoxic agents such as cytarabine or daunoromycin. That you will learn it in internal medicine. Or non-chemo drugs to force differentiation. For example, in promyelocytic leukemia, we're using the ATRA, all-trans-retinoic acid, that combined with arsenic trioxide used to acute promyelocytic leukemia. Please don't use carrot juice, okay? Because carrot juice contains all-trans-retinoic acid, but a very few amount. You have to have much higher dose, and usually this chemotherapy is used parenterally, not orally. Now, the therapy targeting the leukemoid specific genetic mutation under the development, that can be some biological therapy as well in the future. Allogenic stem cell bone marrow transplantation is used, but usually in consolidation. First, the patient, when he's responding to the chemotherapy, after they can use this allogenic stem cell therapy. And of course, the supportive treatment could be used when somebody has anemia, for example, or neutropenia, or if they do have more, for example, you can use some leukocytopharesis by removing the white blood cell count and give patient thrombocyte or red blood cells. And in allopurinol, when the patient has an increased uric acid level, and in infection, you can use antibiotic or other necessary drug. Now let's see another big category. That other category is called the myeloproliferative neoplasia. When we do have an increased proliferative rate, that's a chronic situation. And this kind of disease, what we do call as a myeloproliferative syndromes or chronic myeloproliferative diseases. Now, this is a group of disease which the following characteristic. First of all, we do have a clonal abnormality of the hematopoietic stem cells, and there is a proliferation in the bone marrow affecting several myeloid cell lines. But one of them is emerged as a dominant, such as, for example, the platelet, maybe the red blood cells, maybe the myeloid cells. So this process leads to the increased number of differentiated cells in the periphery. And fibrosis is usually only the secondary phenomenon. And another important one this chronic process may turn into acute myeloid leukemia. It takes time, but they always, let's say, turning to the acute myeloid leukemia. Now, the myeloid proliferative neoplasia usually is distributed or they differentiated based on the presence of the Philadelphia chromosome. Chronic myeloid leukemia has Philadelphia chromosome positivity. Other ones, such as a polycythemia vera rubra or essential thrombocytopenia or idiopathic myelofibrosis, relatively they do not have Philadelphia chromosome. As you learn, the Philadelphia chromosome, a reciprocal translocation between two chromosomes, chromosome 9 and 22. Now, let's see some other comparison of the major myeloproliferative neoplasias. This is the cell line that is affected, the dominant cell line. In CML, the granuloid cell line is affected mostly, but for sure we can have an increased megakaryocyte count or further erythroid increase in the bone marrow can be. The leukemic transformation is usually, it's about 100%. So if somebody has CML, without treatment, 100% of the patient will transfer to acute myeloid leukemia. Now the genetic, this is a Philadelphia chromosome, but a consequence of the Philadelphia chromosome is a BCR-ABL translocation. But BCR-ABL can happen without having the Philadelphia chromosome as well. That's the most important one, to have this BCR-ABL translocation. Later on I will explain it. Or essential thrombocytosis, for example, we do have the megakaryote cell line increases. Or when we do have polycythemia vera rubra or myelofibrosis, idiopathic myelofibrosis, as you see here, the different cell types will increase. And they do have different transformation capability. In essential thrombocytosis, less than 3% will convert it to myeloid leukemia, but any polycythemia vera, less than 50%, and myelofibrosis, less than 20%. And in this case, the common one, they don't have this BCR-ABL translocation, but they do have another kinase mutation, that's a JAK V617F gene mutation, and that will be the essential for these myeloproliferative neoplasias. Now again, very similarly, that's a peripheral picture when somebody has a chronic myeloid leukemia, but we talk about the epidemiology and so on, the old situation what I mentioned before. Now let's see the epidemiology and etiology. About 50% of the all leukemias in a chronic myeloid leukemia, so relatively is very common one. Then other very common one, or the most common one, is a chronic lymphoid leukemia that we will discuss later on. Epidemiology. It may occur at any age, but usually is most common between 50 and 70 years of the old people. The incidence is not too many, because 1 to 2 per 100,000 per cases, and usually the prevalence is increasing is due to the therapy, because now we do have a very good therapy as a kinase inhibitor that relatively more people will survive, and this is why the incidence will increases. Etiology. If somebody is suffering for a high dose radiation, that for example a long time ago in Chernobyl, as you do see here, usually in male, immediately within 10 years they are going to develop acute leukemia, a very high rate, and after it will decrease. And usually the female, they don't have, a little increase they do have, but not too many as a male person. But the majority is unknown. Now what the pathomechanism of the CML. This is an abnormal tyrosine kinase development happening when we do have this BCR-ABL fusion gene. Now these two genes is located in two different chromosomes, and ABL is found in a chromosome 9 and BCR, maybe I can show here, BCR is located in chromosome 22. They are going to code a certain protein. Now, when they do have this reciprocal translocation, and especially on this translocation is stick to the chromosome 22, this gene, they don't have a stop codon between these two genes, and this way they are going to convert a protein or synthesize a protein, and completely abnormal protein. This doesn't have any kind of physiological effect in our body, but accidentally they are tyrosine kinase activity. That's an abnormal tyrosine kinase, and our body responding to this tyrosine kinase by proliferation. So this will increase the proliferation rate of certain cells. Now, this is the BCR-ABL fusion gene. Oh, that's a chromosome that I mentioned, the Philadelphia chromosome. That's okay. Now, in some cases, as I mentioned before, that we can have this BCR-ABL translocation without having any kind of Philadelphia chromosome, but the disease further will increase the rate of some other genetic or chromosomal instability that later on they be affected and they have more acute leukemia to develop. Now, what is the course of the CML without having any kind of treatment? Okay, normally we do have a chronic phase. This chronic phase lasts for months, and after somehow the accumulation, a slow accumulation is happening of the blast cells in the bone marrow, and this is called the accelerated phase. And when we reach the 20%, now that's a blastic crisis, and the patient responding to this as an acute myeloid leukemia. And long time ago, what they did, they treated the patient as a patient who had acute myeloid leukemia and went back to the chronic phase, this consolidation phase. And again, a few months or maybe a year later on, they had an accelerated phase and the blastic crisis. Usually, these patients who had no treatment, or let's say no specific treatment of chronic myeloid leukemia, they developed acute leukemia within 3 or 5 days, and they didn't respond to any further therapy. Today's, however, we do have a much, or let's say, advantage to treat the CML. Now, how the CML looks like in the peripheral smear. In the peripheral smear, we do see a qualitative and quantitative changes. First of all, the leukocytosis, we can have as much as 300 giga/liter of white blood cells. This is the first case. CML was the first when they described these leukemias, white bloodish, where the patient has CML. Now, we do see the all stages. From the beginning to the end, everything is there. Basophilia, the basophil granulocytes count could increase to over 5% or so. And thrombocytosis can happen, but anemia. Later on, thrombocytopenia can develop in this patient when the bone marrow is occupied with these blast cells. Now let's look at the bone marrow. In a bone marrow, when you look at the bone marrow, that's hypercellular. When we mentioned the normal hematopoiesis, I mentioned that mostly we do have myeloid precursors in the bone marrow and less erythroid. The normal ratio is about 2:3 to 1. So we have about 3 times more myeloid than erythroid precursors. In this situation, however, the myeloid cell type is about 10 or 30 times higher than an erythroid one. And we do have myelocytes, a lot of myelocytes. So that's be the most common cells in the periphery and in the bone marrow as well. And an additional one, as you see here, a lot of megakaryocytes can be seen. And usually about 30-40% of the cases, we can have the sign of fibrosis as well, so myelofibrosis. The clinical symptoms it can be very similar to the acute leukemia, except they are not developing so fast. Now, and usually the patient, when they do have the chronic phase, they have no symptoms at all. So they have a very good normal situation, normal lifestyle. Sometimes the spleen enlarging, showing that we do have a infiltration of the cells in the spleen or in the liver. Patient could sense some kind of sternal tenderness, but similarly to the acute leukemia, weakness, tiredness, night sweat, fever, weight loss can develop. Thromboembolic complication may occur in the chronic phase. Hemorrhagic diathesis, bleeding tendency, usually in an accelerated phase can occur when the disease is progressing. Anemia, very similarly when we do see the accelerated or blastic phase. And a large number of leukocytes can accumulate in the periphery that can cause leukostasis, as I mentioned before. And hyperviscosity, similarly to the acute leukemias, and for sure this patient has an increased risk for infection because these granulocytes are not normally fully developed granulocytes. And osteomyelofibrosis may occur, and very similarly gut attack can occur, especially when we start treating the patient. Now look at the splenomegaly. This is the spleen. Usually they are not exceeding the ribs, but here is a very huge, very big number of the spleen. So that's a characteristic feature. If somebody has this splenomegaly, most probably the patient has chronic myeloid leukemia. Now, diagnosis. How can we diagnose chronic myeloid leukemia based on the clinical symptoms or taking a peripheral blood smear? We do see the granular decrease of red blood cell count, so anemia can develop. Initially, we do have an increased platelet count, and after progressive decreases, and the granulocyte count steadily increases with more than a few blast cells will occur. In the laboratory, we do see this a sign of an increased uric acid level, and LDH increase, or vitamin B12 level can be increased. But bone marrow smear should be taken immediately, or cytogenic evaluation such as showing the Philadelphia chromosome and detection of BCR-ABL fusion gene. Usually this is the easiest one and the fastest way to detect it by FISH. And if you do see this fusion gene, that immediately you can say that the patient has chronic myeloid leukemia. Now, I mentioned before that CML is similar to the leukemoid reaction, or leukemoid reaction is similar to the CML. So we do have an infection or a bacteria induce very strong response reaction in the body that induces the leukemoid reaction. That's in the periphery. That could be identical with the CML. But how can we differentiate between these two? Because the clinical sign is very similar one: fever, infection, and increased number of white blood cells. First of all, we can measure the BCR-ABL translocation, and in leukemoid reaction there is no BCR-ABL translocation at all. Another thing it's very important one, the toxic granulation. If a good hematologist can see in the periphery that those granulocytes, what they do see, it's full of toxic granulation. What is a toxic granulation? Toxic granulation usually is a big, dark granulation, a purple granulation, and almost full of the cytoplasmic granules that usually the NAPTH or myeloperoxidase inside, and that's meaning that these cells is fully active, fully stimulated. There was a other test, for example, the cytochemical staining method, that's a granulocytes alkaline phosphatase measurement that sometimes they still used it, or the leukocytes alkaline phosphatase, that's an intracellular in the cytoplasm they are checking, that's enzyme activity. And normally these granulocytes is active. When we do have, however, a CML, they are not active because this enzyme system is not fully developed. Another thing that is a good hematologist can see, for example, the presence of these dual bodies. These dual bodies at an abnormal basophilic structure that's a remnant of the root endoplasmic reticulum. I never seen this kind of dual bodies, only in, let's say, a textbook I could see it, but I never seen under the microscope. Maybe I haven't seen too many slides, but most commonly the BCR-ABL and the toxic granulation and the leukocytes alkaline phosphatase can help us to differentiate the CML from the leukemoid reaction. That can be very important, especially if somebody is suffering of a very severe infection, because when you use an antibiotic, when you change the antibiotic and you have to use very drastic treatment of these bacteria, and usually every abnormality disappears. However, in CML, no. Infection will decrease and you cure the patient, but after stopping the administration of the antibiotic, it's coming back again. And this patient will have repeated, for example, pneumonia for a banal flu, after a banal flu. However, a leukemic reaction after the treatment, everything be normal, normal cell count, normal cell types, everything be back to the normal situation. Now, the previous slide that I showed you in the periphery, how we can differentiate CML, AML. Again, here we do have every cell type in the periphery. In acute myeloid leukemia, we have a hiatus leukemicus, and normally we have only the maturated cells in the periphery. Therapy of the CML. That drug therapy that they developed, that's a tyrosine kinase inhibitor, that was the old one, the first one that they discovered, that's a Glivec or imatinib mesylate. And what it does, that usually this will inhibit this tyrosine kinase that will cause the proliferation. And other drug can be used, for example, the translational inhibitor, homocytoxin can be used, or chemotherapy, hydroxyurea, and usually they use this hydroxyurea to decrease the cell count. This kind of treatment, as in some patients, it can be used for long time, decades, before having any kind of problem. And sometimes it was described that some patient could recover from these diseases because this imatinib, this tyrosine kinase, relatively selected completely out of this clone, and our normal immune system selected out of this clone, and the patient did not have any CML later on, any clone. If not, however, some patient basically after a few years they started to develop further proliferation, and maybe another clone raised, or maybe another genetic mutation happened, and now they develop some kind of new generation tyrosine kinase inhibitors, or they use some other drugs. Now, to cure this patient, this is the allogenic transplantation is for. Usually they use in those patients when they don't have, or they cannot be treated with the tyrosine kinase inhibitor, or they do have a blastic crisis. Now that could mean that this patient can be cured only this way. Now, the side effect of the tyrosine kinase inhibitor is much less relatively than to have this transplantation problem. The transplantation, when you kill the old cells and after homing them and start to grow it, and the patient has a window that they can be infected. So relatively, the allogeneic transplantation has a much more side effect that if the patient responding very well to the tyrosine kinase inhibitor, maybe itself can be used. Of course, supportive therapy has to be applied if somebody has anemia or thrombocytopenia, or their white blood cell count is high. Leukophoresis can be used, or in hyperuricemia, you can use allopurinol to decrease the xanthine oxidase activity, and a broad spectrum of antibiotics can be used in this patient. Now, this chronic myeloid leukemia, as we mentioned, belonging to the myeloproliferative neoplasias, and now we're talking about the Philadelphia chromosome negative situations. Now, in the Philadelphia chromosome negative situation, there are at least, as you see, 1, 2, 3 different forms. One is, for example, that essential thrombocytosis. Here, the platelet count will increase. Sometimes leukocytosis can happen. Microvascular symptoms, especially when we do have a plaque in the periphery, when we do have an abnormal perfusion in the periphery. Splenomegaly is less common one, and thrombocytosis and hemorrhage can happen in this patient. And here you can see the JAK2 mutation is very common one, and this other one is a carregulin or carreticulin. That's an endoplasmic protein, this calcium binding endoplasmatic protein, and they have relatively more, about 1/3 of the cases it will increases. Polycythemia vera rubra. In this case, the first sign can be that the patient has an increased hematocrit or the hemoglobin concentration will increase. Often the patient will have an increased platelet count, and for sure the peripheral resistance increases, hypertension can happen, and thrombosis can develop in this patient, and hyperviscosity can develop, splenomegaly can develop in this situation. And mostly this is about all cases, almost 90% of the cases, we do have this JAK2 mutation. In another, when we do have the myelofibrosis, relatively almost none. The platelet count usually decreases, leukocyte count decreases, and in the red blood cells, if you look at the shape of the red blood cells, they do have the teardrop red blood cells. Splenomegaly, it's more common, about 30% of the condition can occur, and thrombocytosis, hemorrhage can occur as well. And as you see here, as mentioned before, about 20% of the cases can be transferred to acute leukemia. In a case of polycythemia vera rubra, about 10% or 15%, and about 3% in essential thrombocytosis can transfer to acute leukemia. Let's start with the essential thrombocythemia. It is a thrombopoietic monoclonal autonomous proliferation resulting in a slow and progressive increase in the platelet count. Epidemiology, the incidence is about 0.9 per 100,000 persons per year, and usually starts in elderly over 55 or so. Etiology, we don't know. Now, that can be asymptomatic about 1/3 of the cases, and a lot of cases could be manifested in thrombocytosis and hyperviscosity, perfusional problem, and hand and feet and cerebrovascular circulation result dizziness and headache and visual disturbance. So that can be the first sign, for example, in some patient. And because we do have an increased danger for thrombosis, and not only thrombosis, but qualitative problems can occur. In some case, for example, the platelet function is abnormal. This is why the hemorrhage can develop. Not only thrombosis, but hemorrhage can develop in this patient, and splenomegaly and fever in some case can develop as well. Now, how we diagnose? If you look at the blood smear, we do see a lot of platelet, lot of thrombocytes. It can be over 600 gigaperliter. It's a very high number. In the bone marrow, we do see a lot of megakaryocytes. And in genetic, we can have about 50% cases. We have this JAK2 V617F mutation, and Philadelphia chromosome is negative. We have to differentiate for sure the myelodysplastic syndrome or idiopathic myelofibrosis or polycythemia vera and CML, but CML can be differentiated very easily. If you are measuring the Philadelphia chromosome, it should be positive in CML. The treatments in the disease is clinically heterogeneous. Usually, when it's asymptomatic, or you can prevent, for example, the thrombus formation, and especially in high-risk patients, you can use hydroxyurea to decrease, let's see, the cell count, in less frequently using interferon alpha that inhibit the thrombopoiesis, and they are using a inhibitor of the aggregation of the platelet, but using acetylsalicylic acid, for example, or clopidogrel can be used. Or mild level risk, aspirin, for example, used, or in low risk, relatively they are not using almost in nothing, but you have to control the patient. Now, this is how it looks like. In the periphery, we do see a lot of platelets, as you do see these eosinophil dots or aggregated platelets. And the bone marrow, we do see a lot of megakaryocytes. This is not as hypercellular as in CML, and only the platelet count is very high, for example, in this patient, what we had. Now, idiopathic myelofibrosis, relatively, this is an advanced fibrosis in the bone marrow or in the hemopoietic bone marrow, and extramedullary hematopoiesis can occur in this patient in the liver or spleen, and hepatosplenomy can happen, and you can have some nucleated red blood cells in the periphery. Now, epidemiology is less comparing to the essential thrombocythemias, and this is again usually affecting the elderly one. Again, we have no idea what the cause is, and the disease has two phases. In early one, we do have the hyperproliferative stages. The patient usually has leukocytosis, thrombocytosis. Later on, thromboembolism can develop. And the late fibrotic stage, exactly the opposite happening. We do have pancytopenia and can cause anemia, thrombocytopenia, infection, bleeding, and so on. Hepatosplenomy can occur, and abdominal discomfort can occur, and general fever, weakness, and fatigue. And as we mentioned, about 10% usually can convert to, or maybe up to 20% can convert to acute myeloid leukemia. Now, diagnosis, again, blood field, again, as I mentioned, you can see thrombocytosis or thrombocytopenia depending on which phase you are. In early phase, usually the cell count is higher one. In later phase, it's be less one. You can take some bone marrow aspiration immediately. In the late phase, we do see almost no cells in the punctured, in the aspirated bone marrow. This is what is called punctio sicca. It's almost nothing in it, no cells in it. And a genetic alteration, this is a JAK2 mutation, can happen about 50%, and Philadelphia chromosome is negative. And the differential diagnosis is very similar to the previous one. Polycythemia, essential thrombocytosis, and CML could be differentiated from this one. And therapy, usually what they're using first, the inhibitors of the megakaryocyte or the platelet formation. This is hydroxyurea or prednisolone, steroids, or interferon alpha. And in early phase, usually the thrombocyte aggregation inhibition, acetylsalicylate, aspirin, or clopidogrel should be used. In the late phase, when the patient has thrombocytopenia or anemia, transfusion can be used, and the curative therapy is allogenic hematopoietic stem cell transplantation in this patient that can cure the patient. This is how it looks like with specific staining. When you stain the fibro tissue, the collagen, this for the collagen staining, as you see that almost no proliferating cells, so that we do have only the connective tissues that accumulates in the bone marrow. Another one is a polycythemia vera rubra. That's a disorder. Again, the hemopoietic stem cells characterize autonomic increase in erythropoiesis and a lot of red blood cells, and can alter the thromboid, that the thrombocytosis can happen, and some cases in granuloid cell count can increase. The incidence is about 0.7, so it's very sad. Again, the onset of 60 or elderly one. Again, hyperviscosity that can alter the microcirculation, perfusion defect of the hand and feet, the cerebral circulation can be affected, or due to the increased erythrocyte count, hyperoxygenation of the blood, so blushing, plethora, for example, may occur in this patient, and erythromelalgia, for example, resulting from the combination of previous 2 points, sudden painful reddening of the extremities, especially when we do have a plug, and this necrosis can develop, an increased risk of thrombosis, but at the same time, abnormalities of platelet function can result in hemorrhagic disorders, and about 10% in a case this will convert to acute myeloid leukemia. Now, polycythemia vera, how do we diagnose it? We can measure basically the red blood cell count, the leukocyte count, hematocrit, hemoglobin concentration, and another important one, the erythropoietin level decreases in this situation. Bone marrow can be seen in the bone marrow, increased myelopoietic cells and erythroid dominance. And the genetic marker, very similar to the others, on JAK2 mutation can happen. Philadelphia chromosome usually is negative, and polycythemia and the PRV1 expression it increases in this situation. Differential diagnosis mostly could involve the secondary erythrocytosis. We do have another slide. And how can we cure it? Basically, if the patient, who has a huge number of red blood cells, you can use, for example, a little blood withdrawal for a patient, and another thing that can develop in this patient, the hemochromatosis that can cause, or erythrocytopheresis can be used, for example, with a special cell sorter mechanism and inhibitor of the bone marrow proliferation, interferon hydroxyurea can be used. And for sure, this patient will be given acetylsalicylate and clopidogrel as well to prevent the clot formation. Now, the secondary erythrocytosis, when we do see an increased number of the red blood cells, can be due to decreased plasma volume that happening, for example, in exicosis or hemoconcentration or exicosis. And another thing, the opposite of the polycythemia vera rubra, when we do have an increased erythropoietin level. Now, that can be exogenous when somebody is using, for example, EPO for a doping. Now they are using less and less because they can show it and can detect very nicely. Or can be endogenous, can be autonomous. For example, if somebody is suffering of a paraneoplastic syndrome in a kidney, liver, ovarian carcinomas, that will increase the erythropoietin level, and this is why the patient will suffer of the polycythemia. And can be due to the compensatory reason, because when we do have a hypoxia, and this is why it induces the erythropoietin synthesis, such as, for example, when we live in a high altitude, or smokers, for example, can have polycythemia, secondary polycythemia, but endogenous other, for example, pulmonary diseases. Now, this is smoking can be seen here, for example, chronic obstructive lung diseases, or heart diseases, or different type of hemoglobinopathies can cause a secondary erythrocytosis. Polycythemia vera rubra, as you see here, a lot of crowded red blood cells. You do see some platelets as well, and some myeloid cells as well. So as you see here, the hematocrit increases, red blood cell count increases to 8 millions or so, and white blood cell count about double, and the platelet count increases. In this situation, almost every cell type is increased in this patient. Now, the last one that we are discussing, that's a myelodysplastic syndrome, or MDS. That's a group of malignant clonal hematological diseases of the bone marrow. They are characterized by ineffective hematopoiesis, and this will lead to dysplastic morphological bone marrow. Usually, cytopenia can occur in the periphery. And this disease very frequently turn into the acute myeloid leukemia. As you mentioned in the WHO classification, that was a second group when the patient showing the sign of the myelodysplasia. Now, in myelodysplasia, we do see these atypical dysplastic cells are seen in the bone marrow in one or more cell line that affecting the erythroid, the thrombocytic, or granulocytic lineage. And this erythropoiesis occurs, for example, and fragmented nuclei, or tripolar mitotic cells, or ring sideroblasts, that's important, due to the abnormal iron utilization in the cells. abnormal thrombopoiesis. Megakaryocytes may be mononuclear or binuclear or may have fragmented nuclei, or abnormality of the granulopoiesis, toxic or missing granules, or Pelger cells. It's very characteristic of Pelger cells. When you do see these hematological cases in the 5th year, you will see some. Maybe I will show you later of these Pelger cells as well. Now, most important ties that when we do have only the single lineage dysplasia, or we do see this ringed sideroblast associated by dysplasia, or mononuclear megakaryocytes, we do see. Now, these are the better prognostic myelodysplastic syndrome. And if we do have a multilineage dysplasia or excess blast, that's a worse prognostic feature of this myelodysplastic syndrome.